and welcome once again to the teaching class of Department of Urology, SMS Medical College, Jaipur. So today we have a teaching class on Genito-Urinary tuberculosis, and this would be presented by Dr. Dhruvan, our resident, and would be moderated by our faculty, Dr. Bamaniya. So welcome, Dr. Manoj, and kindly moderate the session and ask the presenter to start the session. Dr. Dhruvan, you can just start sharing your. Dr. Dhruvan, go ahead. Yes. Full screen, please. Full screen, please. Mr. Nimesh, unmute him.
Sir, done.
Go ahead. It's full screen, please. Full screen.
इंटरव्यू करते नीचे ना 3 वो होती हैं स्लैब उसको
Try to avoid any conversation. Full screen again. Yes. Go ahead.
Thank you, sir. So, good morning, everyone. Today I am going to present on genito-urinary tuberculosis. So, epidemiology. This is one part of the world's population is thought to be infected with Mycobacterium tuberculosis complex. GTB develops in the 2 to 20% of pulmonary TB cases. In developed countries, percentage is less, it is 2 to 10%, while in developing countries, incidence is higher at around 15 to 20%. And it is the second most common extrapulmonary sites after the lymph nodes. Infections, sequels, when infected aerosols are entered into alveoli, it is a phagocytosis by macrophages. And if it remain alive, it goes into lymphatics and hilar lymph node and spread by hematogenous route. In the worst response, it causes the formation of granuloma by center-forming macrophages, epithelioid cells, Langhans cells, and surrounded by cuff of lymphocytes. There is another type is latent TB, in which the bacilli stops replicating and become dormant, marked by cicatrization and granuloma calcification. The development of GU disease, it is by various route. The most common is a hematogenous spread. In this, the primary landing sites are kidneys and epididymis, and a contiguous spread to other sites of genito-urinary tract. Ascending or retrograde infection. In this, there is a due to bladder irrigation with BCG in treatment of CA bladder, which is derived from Mycobacterium bovis. And the cases include cystitis, pyelonephritis, renal abscess, prostatitis, epididymitis, or uteric obstruction. Contiguous spread is from the spine or psoas muscles to kidney or gastrointestinal tract to genito-urinary, like enterorenal or enterovesical fistula. Direct inoculation can occur, but it is very rare. Auto-inoculation from infected stool and urine can occur. In the kidney, 80% of genito-urinary tuberculosis occur in the kidney. Infection is caused by bacilli in the periglomerular capillaries from the granulomas, which form CALYX and causation leading to cavities with necrotic materials. Frank abscess, chronic pyelonephritis, parenchymal and papillary necrosis, which ultimately leads to inflamed and calcified CALYX. It causes distortion and dilatation, stenosis of CALYX. With enough disease progression, it leads to non-function of kidney called autonephrectomy. It is present up to 33% of the patients with GUTB. It is of two types. Cavernous type. In this tissue is viable with granulomas and filled with inflammatory exudate. And in the type of fibrotic, there is a severe scarring and calcification resulting in shrunken kidney. In the ureter, it is by descending route, in which bacilli in the urine leads to granuloma in ureter wall, or it can occur by infected calculi. Inflammation leads to scarring, usually distal ureter and VUJ is involved, and sometimes pan-ureter strictures can occur. A distortion of ureter lead to both obstruction and reflux. This obstruction result from stricture is an important cause of renal failure. In the bladder, it is also caused by descending route. It starts from the ureteric orifice and spread via lymphatics. Dome is the most affected part, and trigone and bladder neck are generally sparing. It causes cystitis, granulomas, and which lead into ulceration. Mucosal friability and hematuria can occur. And delayed consequences, mucosal scarring, which lead to bladder contracture with reduced bladder capacity, ultimately lead to thimble bladder, which capacity is less than 20 ml. Epididymis is the second most common site of involvement in genito-urinary tract. It's spread via hematogenous. It starts from the globus minor part and is present up to 10 to 55% of the GUTB. Bilateral case seen in the 34% of cases. Infection may spread to vas. And isolated testis or epidermal presentations are rare. Granuloma of seminiferous epithelium and connective tissue of testis. It is replaced by granulomatous tissue. Hydrocele is seen in 5% of cases. And prostate in seminal vesicles, it is by two routes, hematogenous or urinary route. In case of hematogenous spread, lesions in the periphery and asymptomatic and progressive calcification and gland hardening is seen. Urinary route, it involves generally urethra. Present as bacterial prostatitis. On DRA, prostate nodules are present. Seminal vesicles, it is spread to the seminal vesicles by vas or through the ejaculatory ducts. It causes granulomas in the wall, cassation in the lumen leading to calcification. It can lead to low volume ejaculation, oligospermia, azoospermia, or hematospermia. On examination, a large gland is seen in early phase and then nodular in advanced case. Urethra is comparatively resistant to TB. Isolated case of urethral TB is very rare. Penile TB is also rare. Inflamed papules or keratotic lupus vulgaris is seen. Another one is orifacial TB, which causes a rapidly necrotic form of penile TB seen in the immunocompromised patient. TB of vulva, vagina, or cervix, it causes dyspareunia, postcoital bleeding, pelvic pain, and infertility. And in case of uterine TB, it leads to dysmenorrhea, vaginal discharge, or menstrual bleeding. Also complain of abdominal masses and pain. Ovarian and fallopian TB, it is generally diagnosed when workup for the infertility. Clinical features, most common clinical features are low urinary symptoms, and dysuria is present in up to the 50% of cases, and 33% patients have hematuria and flank pain. Less than 20% of cases will present with constitutional symptoms like fever, weight loss, anorexia. Renal colic is seen in the less than 10% patients. Sometimes hematospermia is also present, but it is a less, and in a very rare cases, infertility may be the first presentation. Signs, epididymal is thickened, non-tender, nodular. Vas deferens is beaded and thickened. And the scrotum, there is a pathognomonic sign. There is a sinus on the posterior surface. Is a chronic cases. Penis and urethra involvement, it is rare. When occur, this shows ulceration, urethral stricture, or discharge. And fistula, renal fistula is seen when after the history of prior surgery. Prostatic nodules on rectal examination can felt. And left findings include sterile pyuria or the hematuria or a combination of both. Diagnosis. Goal of the diagnosis workup is to isolation of this microbiome tubercle bacteria and culture for the susceptibility of antibiotic. When culture or DNA test negative, tissue samples demonstrate the cases and granuloma can use for diagnosis. And in case of both are negative, diagnosis rely on the consideration of consistent clinical findings in patients with probable exposure and response to empirical therapy. Workup routine investigation blood are done to assess the severity of disease and response to the treatment. AB smear done, which is shows the AB in urine, and sensitivity is less than 50%. Organism considered requires 5 to 10,000 bacilli per ml, and minimum of 50 ml urine of first weighted morning meal is required. And the gold standard current investigation use is urine culture for acid-fast bacilli. In this also there is a first weight urine is used, and sample is taken for 3 to 5 consecutive days. And culture should be done immediately because the acidity of urine can retard the mycobacterial growth. Sensitivity is 80 to 90%. It is cultured on the two types of media. It is solid and liquid phase. In solid, there is a Lowenstein-Jensen medium. It is generally a medium of choice in the developed country. It takes 4 to 6 weeks. Another one is a Middlebrook 7H10. It is cultured on agar-based transparent solid media, which is take 1 week earlier than the LG media. And liquid-based media, it is done by Bactec microbacterial growth indicator tube. It is fluorometric techniques. Its sensitivity is 95%, and it takes only 10 days to get result. And guideline recommend the culturing on at least one solid medium and with this. Nucleic acid amplification test. It is a result within 1 to 2 days and can aid the detection in patient with a low bacillary load. Non-respiratory specimens such as urine contain natural inhibitors that interfere with the DNA or RNA amplification process. It is lowers the sensitivity of this test. Another polymerase chain reaction tests are available, which is genus specific and species specific, and amplified mycobacterium tuberculosis direct detection test and gene expert, which has sensitivity up to the 100%. Histopathology is considered only in 38% of TB. It is usually when there is a cultures are negative, and it is when mycobacteria are not seen, but finding of gazetting rheuma is in the appropriate clinical concerns help the diagnosis of tuberculosis. The two screen tests are tuberculin skin test and interferon gamma release assay. It is used to test the screening of individual for presence of latent TB infection. Radiography. The first one is a plain X-ray, which shows general calcification in more than 50% cases. In early, there is a faint punctate calcification, and then in the late phase, there is the globular calcification, and the corresponds to the shape of the mass. And cement or putty kidney, it shows small shrunken, calcified, and calcific kidneys outline the renal lobes. It shows the calcification on the right kidney, and these are lower pattern and the shape of TB mass, and which is a pathognomonic sign of end-stage renal TB. IV is the gold standard for imaging early renal TB. It is good in delineating calcial anatomy and distortion, and more than 70% cases single kidney involved. It used to access the response to the treatment or any look for complications. First, earliest abnormality is a mouth-eaten appearance. It is due to irregularity of papilla and CALYX with normal renal size. Another is a phantom CALYX. It is occurring in the TB. The smoothly tapered infundibulum, which is contrast is not visible in the CALYX. Another is a Kerr-King sign is a cortical scarring and dilatation of CALYX lead to strictures, cause luminal narrowing due to causing kinking of the renal pelvis at PUJ. Another sign is a Golfonon T. In this collecting system, contrast material is a large papillary cavity with blunted calyx. In the multiple ulceration, there is ureter causes sawtooth appearance. Another is multiple strictures may create a long irregular urine, will lead to corkscrew ureter, and rigid ureter due to lack of peristalsis, and dysfunctional fibrotic stricture leads to pipe stem ureter, and reduce capacity and diminutive irregular urinary bladder, it called a thimble bladder. CT urography, it is a high sensitivity. It can detect the lesion small as 3 to 4 mm. With intravenous contrast, can assess the kidney function and calcification and scarring. Its disadvantage is a higher radiation dose and is less sensitive to detect in the minimal urothelial thickening. Another early changes like papillary necrosis, and for which IV is still preferable. This is a calcification and callus dilatation seen in CT. And in the lower image, it shows the hydronephrosis, and other side is atrophic kidney with calcification. It is variable findings are seen in the CT. One is a pelvic dilatation with parenchymal scarring, and lower there is a multiple strictures are seen in the ureter. Retrograde pyelography. It is used when the patient is in CKD or allergy to contrast. Cavitations are obstructing or not obstructing, whether communication is present or not with the collecting system, and non-functioning kidney to demonstrate the ureteric obstruction. It is shown there is a upper calyx is a stenotic, so associated with papillary necrosis. Anterior pyelography is not used generally, is used when retrograde access is not possible, and done by placement of nephrectomy tube. USG, it is done in the pediatric and pregnant patients to less the exposure of radiation. It uses generally to evaluate the testis, epididymis, and abscess in the kidney. It can use for follow hydronephrosis when patient is on anti-tubercular treatment, because sometimes fibrosis can worsen the urinary obstruction. MRI is also used in pediatric and pregnant patients to avoid radiation. Small lesions are hypointense in T1 and T2 images, where large lesions are shows the central hyperintensity. It is more sensitive than IV in urothelial thickening and calcitosis. Cystoscopy and ureteroscopy, it shows local hypemia, mucosal erosion, granular masses, and gold fold uretary orifice, suggestive tuberculosis, and it can indicate the upper tract imaging. Biopsy is diagnostic only in 19 to 52% of cases. It is the findings of cystoscopy. There is a granuloma, and in the images is a ulceration. Both lower images shows the gold fold ureter. Treatment, most of the TB patients treated with medically, with even with MDR TB. Medical therapy involved when activated, it includes the short course therapy. It includes 4 months therapy, 4 drugs for 2 months and 2 drugs for 4 months, a total of 6 months duration. Rifampicin, isoniazid, pyrizinamide, and ethambutol. There are 2 types of category. For the category 1 include the new cases, smear positive, sputum smear negative, or other extrapulmonary, which include 6 months therapy. And category 2 patients include smear positive relapse or failure or treatment defaulter. It include 8 months therapy, 2 for HRGDS, 1 HRGD plus 5 HRE. Successfully treated with the standard short course regime of 6 months of first line in ATT. Long 9-month treatment is recommended for the extensive progress of infection concurrent with the positive pulmonary disease, central nervous system involvement, and delay in the negativity of culture. These are the first line anti-tubercular drugs, include isoniazid, rifampin or rifabutin, pyrizinamide, and ethambutol. Isoniazid, rifampin, and rifabutin cause the hepatic toxicity and should be used in reduced dose. And pyrizinamide can also cause hepatic toxicity, and the ethambutol cause visual acuity and optic neuritis. These are the second line drugs, which include streptomycin, capreomycin, amikacin. And then cycloserine, ethionamide, levofloxacin, and the newer one is a bedaquiline. Steroids, it is a cause anti-inflammatory of steroid prevention that unchecked host immune response, which cause excessive tissue destruction and scarring. So it prevents strictures and bladder contraction. In case of severe TB, steroid reduces the mucosal inflammation and improves symptoms. TB is highly responsive to the short course chemotherapy. Culture is generally negative after two weeks of initiation of therapy. Relapse rates are 6 to 22%, and average time for relapse is 5.3 years. Drug resistance, multi-drug resistant TB is resistant to isoniazid and rifampin, in which there is a pyrazinamide, ethambutol with streptomycin, or ethambutol with ciprofloxacin is used. It is given for 18 to 24 months, and cure rate is 50 to 60%. Actionable drug resistant TB is multi-drug resistance plus resistance to quinolones and one of the injectable kanamycin, capreomycin, or amikacin. This drug resistant involves 5 to 6 days, and cure rate is only 30 to 50%. In hepatic failure, isoniazid, rifampicin, and pyrazinamide is used in decreased dose. And in renal failure, if GFR is less than 30 ml per minute, then isoniazid, pyrazinamide, and ethambutol is used in decreased dose, and streptomycin should be avoided. Surgery management, approx 55% of patients with GTB will require surgical intervention. Current focus is on organ preservation reconstruction. More than half of operations performed for tuberculosis are reconstructive. Ideal time is 4 to 6 weeks after initiation of medical therapy. In case of acute condition to relieve obstruction, generally retrograde uterus stenting is done, which is possible in up to 41% patients, and antegrade uterus stent is placed when retrograde is not possible. Nephrectomy, indication for nephrectomy are non-functioning kidney and recurrent TB despite the medical therapy, non-functional kidney with medically resistant hypertension, or it is a coexisting with renal carcinoma. Nephrectomy generally performed 27% of GUTB patients, and in this nephrectomy, individual ligation of renal artery and vein is preferred to limit the risk of arteriovenous fissure. In uretropelvic junction or uteral surgery, upper and mid uteric involvement are comparatively rare and generally seen in lower uterus and pelvic junction. In acute phase, DJ standing or percutaneous nephrostomy tube is done, and if it is deteriorated or no improvement after 6 years of therapy, surgical management is required. In endoscopic is a DJ standing or a balloon dilatation, and open surgical method. When there is a PUJ cases, then dismembered pyeloplasty for extranal cases, and non-dismembered for the longer strictures, or uterocalicostomy can used. For upper and middle uterine stricture, uterostomy is done, and for lower uterine one, uteroneocystostomy or psoas, Boeriflep, or ileal interposition is done. For bladder tuberculosis, when the capacity is less than 100 ml, it can cause severe symptoms for which augmentation cystoplasty is required. And when there is a thimble bladder, there is an orthotopic bladder substitution is required. Augmentation cystoplasty, the general contraindication are for bowel disease and psychiatric disturbances, or when GFR is less than 30 ml per minute. And types are.
Can you go back?
Sorry,
This psychiatric disturbances, okay, unit diversion is better than the orthotopic new blood, then what? Augmentation. This is going all right. So we can ask that question.
The types include cholecystoplasty, cystoplasty, or gastrocystoplasty or ileocystoplasty. For prostate and urethral surgery, indications are bladder neck contracture, prostatic abscess, granulomatous prostatitis, urethral stricture, or tuberculous urethral fistula. Epididymiectomy, it is generally not required, but it required in the cases and abscess not respond to chemotherapy or swelling that increase in size gradually. even after the anti-tuberculosis chemotherapy. Complications testicular atrophy, orchidectomy required in 5% of cases. Vessel or epididymal obstruction, it can lead to infertility. Surgical intervention is generally not useful, and IVF is the option to achieve pregnancy. In special cases in HIV, there's a risk of active TB is 30 times more than normal one. Among HIV persons involved, almost 25% of the deaths are due to TB. Less cases and necrosis due to immunocompromised system. And in this daily treatment is recommended, and rifamycin may decrease the serum levels of antivirals. In renal transplant recipients, allograft TB is rare. It can present 6 months to 7 years after the transplantation. Normal signs and symptoms are absent. Imaging has also poor sensitivity, and fever is the most common symptoms. Rifamycin immunocompromised agents have drug interaction. So rifamycin free regimens is given and generally given up to the 18 months for the duration. Pregnancy and lactation. During pregnancy, therapy should be initiated because the risk of TB to the fetus is more than the adverse reaction of drug. And who recommends the pyrizinamide as the part of standard first line. So isoniazid, ethambutol, rifampin, pyridoxine is given. And breastfeed allow once non-infectious as a drug concentration in breast milk is very low. Thank you so much.
And share your presentation. Thank you. Let's make it full screen. Thank you, Dhruvan, for the presentation. Make it video. Okay, anyway, so okay, leave it. So we will take up a few questions and queries from all of you. In the meantime, I will just briefly summarize the whole thing. See, genito-urinary tuberculosis is a very important topic from particularly Indian perspective. We know about 10 million patients suffer or newly diagnosed tuberculosis every year. So it's a very common problem. And we all know tuberculosis is caused by mycobacterial tuberculosis complex. It's not just Mycobacterium tuberculosis, but there are other bacteria like Mycobacteria bovis, capriti, microti, and even BCG, intravesical BCG that we give, Bacilli calmette-guerin, can cause tuberculosis. We all know that around 1/3 of these tuberculosis patients can present as extrapulmonary manifestation. And of these extrapulmonary manifestation, 1/3, around 30 to 40% could be genito-urinary tuberculosis. So overall, around 2 to 20% of these patients may have genito-urinary tuberculosis. And usually this happens because of the hematogenous spread of the primary focus, which lies in the lungs. And usually it lies latent, and reactivation of this infection results in genito-urinary tuberculosis after a latency period of maybe 5 to 40 years. So again, genito-urinary tuberculosis is often missed because the symptoms caused by this would be often masked by common problems like urinary tract infection. So it is very important to actually keep in mind of genito-urinary tuberculosis if there are cases of resistant or recurrent urinary tract infection. So be very thoughtful when you get a case of recurrent and resistant urinary tract infection, and this could be actually a case of genito-urinary tuberculosis. So we have to think in those lines. Secondly, when we talk about the diagnosis, we all know it has to be diagnosed by proving that there is Mycobacterium tubercle bacilli in one of the secretions, which could be either urine in genitourinary tuberculosis, it could be prostatic fluid, it could be semen, it could be pus from any of these abscesses. So anything, all these fluids, if we can stain them, usually we used to stain by Jaden stain, but now WHO also recommends that gene expert or the CB0 assay is probably the best for diagnosing this genitourinary tuberculosis bacilli. But the gold standard remains the culture. And culture, we know, the conventional was a solid media, LJ media, and then came the liquid media. But now the gold standard is a special MGIT liquid culture automated system. So this is a mycobacterial growth indicated tube liquid culture system, which even WHO recommends now, and the results come quite rapidly. And so this has become the gold standard in diagnosing a case of genitourinary tuberculosis. Then we have line probe assay and that gene expert, as we have already said. And then besides these culture, which is the gold standard, we can also diagnose it by other things like histology. You can take biopsy, and the biopsy can show a granulomatous tissue with the features of Langerhans giant cells and all those epithelioid cells. And the tissue can also be subjected to CB0 and culture, which can ultimately prove tuberculosis. Then we have many imaging studies. So like ultrasound, X-ray, CT scan, MRI, PET-CT, all these are very important in diagnosing genitourinary tuberculosis. And then we have different kinds of scopies, like cystoscopy, ureteroscopy, and then even hysteroscopy, laparoscopy. All these would help us to diagnose various types of genitourinary tuberculosis, both in males and females. So when we come to the treatment part, as we all know, it is either medical treatment or surgical treatment. Medical treatment, the conventional has been the 2-drug therapy for 4 drugs for first 2 months, and then 2 drugs for next 4 months. But with the advent of MDR, multiple drug resistant tuberculosis, we need to know and very carefully that there is a second line of therapy, which includes the different types of fluoroquinolones, then aminoglycosides, and there are other drugs also which could be used as has already been mentioned. So, and then surgical therapy, as he has mentioned, initially we can do either percutaneous nephrostomy or stenting, dilatation, etc. And later it may require either nephrectomy or a partial nephrectomy, or even augmentation cystoplasty and different types of reimplantation or ureterostomy, or even an ileal ureter. There are cases, like one case which we came across recently, it is in our wards only, where the patient has a thimble bladder, left side non-functioning kidney, right side also a little poor function kidney. And then he had a case of prostatic abscess due to tuberculosis. It was the prostatic abscess was drained. So when we did a cystoscopy ureteroscopy, there was all a cavity in the prostate region, and his sphincter was also gone. So in such cases, I think even as augmentation cystoplasty would not help, and we are trying to for either a catheterizable pouch or an ileal conduit in this kind of patient. So this is the treatment part, and I think all of you should be familiar with genitourinary tuberculosis, which is a very important topic from our perspective. So Nachiket, the question you had,
Psychiatry.
just tell me, just.
He had inside the slide said that if the patient has got psychiatric illness or disturbances, then we should go for a conduit and not for an augmentation cystoplasty. Why is that?
Okay, so there was one of the slides, Dhruvan said that if the patient has a psychiatric illness, we should go for conduit rather than augmentation cystoplasty. So Dhruvan, just answer the question.
Augmentation cystoplasty, we may need CIC. So it is difficult for this patient.
So what you're saying is that psychiatry has got some psychiatric patients, all of them, they do not have the dexterity to do CAC. I mean, if the patient is depressive, say he has mania, which is a psychiatric illness, then he definitely has dexterity even to go to his office and to do work. Why would that be a contraindication?
I think there was a little kind of probably what he meant is that his psychiatric illness was such that compromised dexterity, probably. So, because what is more important is dexterity, as Nachiket said, is important. There could be many psychiatric illnesses, but he could be very well do CIC. So, psychiatric illness per se would not be a kind of a contraindication for augmentation cystoplasty. Correct. Anybody else has anything to say? So do we have anybody in the chat box? No.
Inside, you said that the incidence of nephrectomy inside GUTB is roughly around 27%. Say that the patient has got a non-functioning kidney, right? And there is no hyperurethral nephrosis. So, I mean, are those patients, should we do a nephrectomy inside those patients? Because there's a problem of spurters also, that these bacilli, they can remain dormant inside neutrophils or inside cavities or in tissue for a long period of time. So, what is your concept about doing nephrectomy inside non-functional kidneys, which are not hydronephrotic? Say a autonephrectomy. So, they can be a source of infection. So, anything, did you read about anything about that?
So, this was a question from Nachiket again, that patients who are not hydronephrotic but non-functioning kidney, they could be a source of infection to the systemic infection to the other kidney also. So, would you do a nephrectomy in these patients? I will ask.
So, it can cause a infection by spread to adjacent organ, like formation of.
So what will you do?
So nephrectomy should be. Nephrectomy is indicated in patients.
Yes. Yes. Yeah. So yes. So all these kidneys should be removed. If the kidney is poorly functioning, very poorly functioning, and non-functioning, putty kidney is already an autonephrectomized tissue, a kidney. So again, there was one more, I think I might add, in the diagnosis and investigation part. Now people are doing an LMA assay. LMA assay is a lipo-arabomenon assay, which comes from the bacterial cell wall glycoprotein. So urinary assay of LMA is being also included in part in the diagnosis of Mycobacterium tuberculosis, which can rapidly diagnose GUTB. So that was all about genito-urinary tuberculosis. If you do not have any other question, we will wrap up. Manoj, yes, come here. So Dr. Manoj is the moderator today, so I would request him to give his last comments and yes, question and comment, and then wrap up the session. Come. Yes.
Sir, my question to sir, respected sir, to you and to adult patient present with lower urinary structure, but history of the pulmonary tubing in the previous, but now no urine culture is sterile, no AFB in the culture, and no evidence of any tuberculosis. In this case, it is given.
See, many a times, sometimes you would not be able to get culture positive, but the systemic signs, symptoms, and the radiology, if are suggestive of tuberculosis, then you can go ahead and give empirically anti-tubercular therapy. So it is not always, it's a kind of a mandatory that you have to get a culture positive to start anti-tubercular treatment. So there are guidelines for that if 2 or 3 of this becomes positive, either the clinical signs and symptoms, the radiology, or sometimes the histology, even if the culture doesn't show positive. So you can start empirically anti-tubercular therapy. So it's not necessary that always you have to prove it by culture, but definitely it's the gold standard. Yes. So thank you, Dr. Manoj. Dr. Manoj, just say thanks to all and just
thank you. Thank you. Happy New Year, all of you, and thank you, Dhruvan. Thank you, sir. Thank you, sir.
So thank you once again. And yes, Happy New Year to all of you and have a good day. Thank you.